Hello and welcome to another episode of Sacktown Talks. Today we have Dr. Colin Mangham here to talk about safe injection sites, an issue that's come up this year in legislation. Dr. Mangham, thank you for joining us and welcome.
Thank you for having me.
Can you kind of give us some background, I guess, on your, your expertise in this area and kind of how you came about to be, interested in this topic?
Well, my career has entirely been in Canada, in the field of addictions, working with communities, working with families, and with governments, in government and around government, in drug policy and drug strategies. I've taught and done research in this area with universities and over the years, and particularly have helped train individuals in community organizations. I have presented testimony to the federal government, two bodies of the federal government here in Canada, and also to the Standing Health Committee as they considered injection sites, causing me to have a close look at this particular strategy. It was emerging in the 1990s in Canada, not formally really until 2007 with the formation of Insight. I was asked by one of the funding partners of the Vancouver project to examine the research, to look at the research that was being done at the beginning of Insight, to evaluate it, and as I did that, I was quite surprised with what I was finding, but that we were getting caught up in a more of a political and ideological battle than a scientific one. And that's true, you know, in many areas. I wish it weren't. Addiction shouldn't not be politicized, but that gives you a little bit of what I've been involved with over the years. I'm actually from Texas. I've served in the Navy in Washington, and my wife's Canadian. If your listeners say, well, this guy's not Canadian, I have lived here for quite a long time, but I've never quite lost the entire accent.
You know, I understand you got your PhD in community health from the University of Oregon.
Yes.
What brought you to bring, I guess, your expertise to Canada?
Well, the short answer to that is when I got out of the Navy, my wife is Canadian, and she got me to move to Canada.
Right.
To home with her, and then I went to university, went to graduate school at UBC, moved into the health area because I was working in addictions, had already started working in the area of addictions, particularly in prevention. And then we went to Eugene, Oregon, and did my PhD there, and went back, and the rest is all history. Worked with provincial government, federal government, Health Canada, the Ministry of Health in British Columbia, Dalhousie University in Nova Scotia, and various other things, and as a consultant over my last 10 years. And my main work was pretty well all in drug policy. In the last number of years, my wife was ill with cancer, and I was her primary caregiver, so I kind of fell out of the work, but I'm trying to get back in a little bit now.
Yeah, it's interesting that this topic of, I guess, safe injection sites has been around for quite some time. I remember it was brought up a lot during the AIDS epidemic as a way to, I guess, provide drug users clean needles to
Yes.
use drugs. I guess, can you give us a little background on the concept between injection sites, and I guess where have they been implemented?
Well, the first injection site in North America is in Vancouver. It was Insight, and it had four goals. One of them was to prevent bloodborne disease. Another was to reduce overdose and to improve public order in the area around where the high, population of addicted persons, and to move them into treatment. It came about there, and that was the first one, and it didn't show effectiveness in any of those areas, overdose deaths, because to understand addiction, you have to understand that it's chemical slavery, that it's a chaotic existence, and it's not, as Portugal's government says, it's not a lifestyle like others that you leave to the individual. The ability to manage life and to have the intrinsic motivation to not to wait till you go to an injection site to use under supervision, it doesn't exist. So only about 5% of injections in the Vancouver area, Vancouver downtown east side, which is the area. Anyone's ever gone on a cruise to Alaska out of Vancouver, it's right near there. With only about 4.5 to 5% of injections are performed in the injection site. So 95% of injections are done on the street, or that it just doesn't have the capacity. It also relies on the individual to have the motivation to delay gratification and go to the inside to inject. So it's not a surprise that it doesn't do those things. You're absolutely right that it came out of the public health area, particularly out of the AIDS area, and many of the lead researchers and proponents of injection sites came out of that and applied that model, or tried to apply that model to addictions, the model of harm reduction or safe injection. Unlike many other areas, there's not the capacity on the part of the individual to openly participate in safe drug use. And so that's been the difficulty. It spread from there. In Canada as well, it was a part of the injection site movement was at the same time to try to change drug laws. And of course, we all know that, over the years, drug laws have been more punitive than helpful. But that motivation set up a political issue in Canada. You have one party that doesn't want to have injection site, the other major party does. I wish that weren't so. I wish we could agree to pursue the most effective responses to drug use. Myself, I don't think that the injection site has the potential to help. It's not feasible. You'd have to cover the entire area with injection sites and somehow motivate people to get into that site the number of hours so that they could inject, and that's night or day. So
yeah, I guess to take a step back, I guess to kind of explain what an injection site is, kind of,
injection sites. Injection site it's a place where the individual may go in. There are nurses and staff. They are ushered in and given a kit, a clean kit. They can go to a little booth and participate, and there they can inject. And the idea being, 1, clean needles, 2, medical people present to prevent overdose deaths. There have only been about 1 or 2 overdoses. Overdose deaths happen generally, if they're going to happen, after the person leaves the injection site. Not surprisingly, no one dies of an overdose inside an injection site.
Right.
And there's it's low threshold, so there's passive information about possible treatment in the form of brochures and booklets. There's not a strong connection to treatment, and that's a weakness certainly here in Canada. The person using isn't sort of, okay, this is an opportunity to properly take care of this, which, and the only answer, it is slavery, and the only real answer, the only compassionate thing is to help the individual get away from the drugs at the end of the day. It's not compassionate to permanently leave a person addicted to opiates or the other injectable drugs.
Yes. So I imagine, I guess, what kind of drugs are we talking about here? And I guess, does the user bring their own drugs with them to these injections?
Well, in the exception made in Vancouver with the Vancouver project was that the police would not prosecute individuals going to the injection site with drugs. And so they got a exception to the normal law that allowed individuals without prosecution or persecution to take drugs into the injection site and inject them. And principally heroin, but also their cocaine. Almost all is heroin, because the other drugs that require frequent injection, the individual would be in and out of insight, and the capacity is just not there. Like I say, its capacity, running at capacity, it's about 5% of injections. So that exception allowed that, and that's been true in Portugal and in other countries that are using injection sites, that an exception is made to the law, and that allows the person to go in.
You kind of said that I guess only 5% of drug users are using these injection sites.
Well, 5% of injections are done there. Most people that use injection sites only do some of their injections there. In the research, originally
being used more consistently, in your opinion?
I'm sorry.
I guess why aren't they being used more consistently by the drug?
Well, it's a building. The drug users live in the area. It would require them to obtain the drug, walk to insight, go in, and then leave and go wherever they go, and then come back. And as well, it only has so many cubicles, and there are probably 1,500 addicted persons in Vancouver, and so in that area, and so it only, that's the capacity. People use it for some, not all. Only 10 people in the original research used it for all of their injections. Most would use it from time to time. Sometimes as a way to think, well, I'm going to use it because I want to be sure I don't have an overdose this time. Maybe they're trying some new combination, or they've increased the dose. But they use it. So in that sense, it's like wearing a condom every now and then. And of course that doesn't work.
Right.
So the challenge is to, in my view, the challenge is to get the most effective method of addressing these deaths and disease is to get the person off the drug, and we're not doing enough there. In a free society, we don't have mandated treatment here. Sweden and Portugal, for example, do. So an individual who and in Florida now they have a diversion program in Miami to divert people who would normally be prosecuted legally. They can go to treatment, and that helps, because the addicted person in the midst of the throes of addiction isn't in a real position independently to say, well, I want to get off the drug. But invariably, once they're kind of off the drug, they're happy to be off the drug. The problem is staying off, because they filter back to the same area where they're at, whatever city that is. And that's the big challenge, is to help them to get training and relocate.
Earlier, you touched upon the fact that I guess there's kind of a safe harbor around these shooting injection sites. Is there been an increase of crime? Is there more drug dealing around these injection sites, or kind of what has the public safety effect been, around these sites?
Well, the downtown east side in Vancouver is very chaotic around Insight and even in surrounding areas. According to the Vancouver Police, at the time Insight began and was evaluated, in part of my critique evaluation of it was a look at their evaluations. They hadn't looked at public order other than looking for needles on the ground. And the police confirmed that it was a large increase in public disorder around Insight. It does form a bit of a nexus. But you have to remember, there are many other services in the downtown east side and probably in other cities, so that there's also a lot of people gathering there, soup kitchens, and other places that people will gather to, seek help, seek services. So the public order in the whole area is not good at all. And you could expect with an injection site, it would be a bit of a magnet. It would be for gathering of addicted persons to the area. But keeping in mind, it would be those who are motivated to use the site. Right. Many wouldn't bother.
As we're experiencing, I guess, this worldwide public health crisis dealing with COVID-19, I guess, has there been, just you describing this, I guess, gathering of people in kind of a small area? One of the big fears here in California, I guess, is COVID-19 getting out in our homeless population. Have you guys seen any impact of COVID-19 within the homeless population?
We've been fortunate in British Columbia with a relatively low incidence of COVID-19 in our public health. Our medical health officer has done a good job with the population as a whole, in social distancing and in quarantining as appropriate, and avoiding gatherings. But you have to remember that that's the general population. Among a street population of persons who are seeking and using drugs and whose own lives may be a bit out of control, the will to social distance is not very high. That they care about being 6 feet from everybody else. They have bigger fish to fry, so to speak.
Right.
And so that's been a concern here, but I haven't yet seen any any hard data about has it affected incidence or not, because as I say, our incidence here is of COVID, it's been primarily in nursing homes and among elderly who are exposed.
Yeah, kind of earlier you were talking about, I guess, the political battle in British Columbia between these injection sites. Kind of what is the argument for continuing these sites and, I guess, increasing their use or making them better? Kind of what are the thoughts of, I guess, pushing this forward?
Well, the proponents of injection sites, they have locked onto this as a path, and harm. It's a part of a broader harm reduction strategy, and harm reduction is simply a way of saying that we're looking at reducing harm rather than concerned about the incidence or prevalence. And in itself, it has a useful place in drug policy, and so they pursue this as a way to try to help people who are addicted to not die, to not overdose, and hope not to get serious bloodborne disease, hepatitis A, AIDS, various HIV. That is the main argument for it, and that's what's being pursued. The problem is that it hasn't been effective in those ways, and it draws money. It's quite expensive. So in a pot of money, when we choose one strategy path, harm reduction, this kind of harm reduction, we more or less start drawing from other possibilities. And that the area that's suffered the most in Canada has been treatment, because it's just not a priority when you're putting your money into injection sites, and that you don't. The two don't go together. One is trying to get people off drugs, and the other is going to maintain them on drugs. And that's become the bit of the political battle here in Canada.
I guess here in California, we're coming off this kind of economic crisis. We have a big budget deficit. I guess resources are limited. Kind of, as an expert in this area, if we're going to focus our resources in one area to combat, the issue of drug addiction, where should those resources be placed, in your opinion?
I would not focus them on injection sites, because you're not improving any problem, and you're not reaching a very high number of the people with the problem. That if you imagine the density, thinking San Francisco as an example, I haven't been there for years, but I know that you have an injection site or 2 or 3 or 4 there, you're still not going to be able to reach very many of those people. If the idea is that we just have to have an injection site for some reason, it needs to be tightly tied to treatment, with the idea of moving people from the injection site. And that was the original idea, was going to move them to treatment. Of course, many of the users, they're not motivated. They're not in a mental place, and it's a sad thing. These are good people who are essentially in a chemical prison. And our role in helping them get out of it involves not just maintaining them on it. That's not compassionate. For one thing, you're not really saving lives. The data don't support that. So treatment is key, and it doesn't have to be hugely expensive, but it needs to be ongoing. And we haven't done a good job of producing treatment that moves a person beyond sobriety to rebuilding their life and their connections and their family, and if any, and their ability to work and produce. I don't think we're going to ever eliminate addiction. It's a human behavior, but there's where the dollars, if we have and we do have a fixed amount of dollars, don't we? You would in your homeless problem, our homeless problem, we can try to get them out of the homeless, or we can just give them sandwiches over the long term, which is helping them. But we have to separate them from those things that are causing the homelessness or causing the drug use in the first place.
You know, earlier you talked about, I guess, how the intentions behind this were to, I guess, give people a safe and clean, place to inject. Kind of what are the statistics behind, these users of these drugs, I guess, getting bloodborne illnesses, with dirty needles, and I guess dying from these bloodborne illnesses?
The incidence of bloodborne disease is high among addicted persons. I don't have the figure of the percentage of them, but left alone in a population without any intervention, it would eventually reach saturation. Everyone who is going to, because, and I believe in the downtown east side, in some situations, it was reaching this saturation point where everybody was being exposed sooner or later. The clean needle programs have had mixed results. In Montreal, they had negative results, and in other places they've had, in terms of reducing disease by giving clean needles. The public can be a little bit revulsed by clean needles, but if you think about it, that's a low level, that's a compassionate intervention to somebody to not reusing the same needle. The problem there again is the will and the desire and to go and get the clean needle and to use it versus just simply using whichever needle's available at the time that the person needs to use the drug. So,
and I guess there's another issue is there sharing of needles between, I guess,
sharing of needles is part of the social. Unfortunately, we're all social creatures,
right?
And so sharing a needle would be considered a kind thing. I'm your friend. I'm helping you out here. I think the education has I think that in terms of sharing needles, I'd be interested to look at the latest data on incidents, the prevalence of needle sharing. Certainly, we flooded the area, and certainly here with needles. They're easy to get, so that one would think there's not the need to share needles. But at the moment of drug use, it's a social thing, and I don't have AIDS, you don't have AIDS, so that we can share this needle. Remember that we're dealing with it's a form of mental illness. So you're not the awareness and care to go and make sure I never share my needle it's not there.
Right. You know, you've mentioned, I guess, other countries that have tried this solution. You mentioned Portugal. I guess, is there a country out there that is, I guess, doing the right thing with treatment and, you know, helping, I guess, people off these drugs? Is there a good model out there you could point to?
There are some models that I would say that are good, but it's a complex problem and a very large problem. You know, it's a huge problem, and I couldn't name a country that has the silver bullet. But I mentioned Portugal as being and Sweden, both very, very liberal countries in the sense of you know, having low threshold programs, not the kind of problems we might have here with legal problems of, you know, that might in the United States and Canada that, well, we don't want people using illicit drugs. But in both cases, in Sweden, which has a lower incidence now than Finland, Norway, Denmark, other European countries, from a baseline, they have mandatory treatment. If a person's receiving government assistance, and most are, like here in Vancouver, pretty well all of the population of the downtown east side, they need help to live. But in order to have that, the person has to accept treatment. That's fairly aggressive. So that they have had does it work for everyone? Does everyone take that and go and not come back? No, but it has had a positive impact in Sweden and in Portugal, which has a similar programming. In Portugal, which is principally in Lisbon, they have developed a major center there for what they call dissuasion, and individuals who are addicted are not considered to be, I don't want to sound harsh, but they don't have the right to simply say, well, I'm addicted and I'm using drugs and I'm not going to change, and so leave me alone. The social costs are such that they've erected a system of sanctions that help the individual, similar to drug courts, to take that step to enter into a program. And in the case of treating addiction, mandated treatment works better than free will, because the person really doesn't want treatment. They may fleetingly want treatment for a bit because they just had an overdose and they had a scare. But if they're not required, your detox centers here are really a revolving door. And I would suspect there as well. The person goes to detox, gets cleaned up, and they just cycle out. They don't really pursue it with treatment. It's just having a little bit of an extra incentive which is where they're saying, if you want to continue to receive help, then our statement to you is to receive treatment.
Yeah, that's an interesting point, because I guess you equated this. You're an addict. You're addicted. You're basically in this prison. You keep going back to it. I guess, how do you break that cycle?
That is the number one problem with particularly opiate addiction. It's a hard cycle to break, and it would involve well past our standard 28-day or 3-month treatment programs, because you have an entire life to restructure and rebuild. And they need help from family. They have family, and families, for example, in Portugal and here in treatment centers, they encourage family. If there's not dysfunction, sometimes the family can be part of the problem, as you know. But to help them with job skills, we have a therapeutic community here in Surrey. A person, Jean Vauquin, who used to own a large furniture chain, decided in his later years to set up a therapeutic community where they actually live there. They work there. They work in a store and live there, and for 2 years. And it's starting to have some impact, but the problem is keeping people there. We don't imprison people. We don't We don't say, all right, you're going to stay here for 2 years and you can't leave. I don't think that would float in our legal systems. We tried mandatory treatment here in British Columbia 30 years ago. I was working in Vancouver, and remember the government at the time built a huge center, going to be a big hospital to treat addicts. And they were challenged in court and were told they can't do it. And that center has gone to a ghost town for the last 30 years, never was used.
Interesting. You know, I guess the theory behind an injection site is basically libertarian. The fact that people are going to go, they're going to do drugs. There's nothing we can do to stop them. So we might as well give them a safe, clean place to do this. And I guess on the other side of it is, you know, I guess this isn't an activity we want to encourage. So I guess, you know, we need to find a way, you know, to treat these people. You know, how are you balancing this? And
you've put your finger on the tension there. Libertarian, civil libertarian is one group of arguments for you know, the person has a right to use drugs. That's very debatable and has been debated. The right to be addicted and to use drugs and to continue and with all that produces in costs to others and to the community. And that tension of, is it a right or not, or no, it's not, we need to, just as we would treat a person of another disease and not just maintain them on the disease, if it was killing them, and it was costing money to other people and affecting their ability to work and function as an individual. I know that civil libertarian argument was used once in a debate I had. You said, well, we give diabetics insulin. You know, that's a difficult argument because there are some significant differences between drug addiction and diabetes. But once you go down that little rabbit hole of debate, it just goes in circles. And what ultimately gets lost is the addict. My professional belief based on the data and my personal view, being compassionate, having children of my own and grandchildren and friends and neighbors, is that it isn't compassionate to write a person off as disposable, that they can be just left to be an addict for their life, or until such time that they might decide to change. The people that don't believe that, we have here in Canada people that believe, no, it's a right, that's their right. And I've been in many debates about that with them in this country. I can see the idea of freedom and ability to choose your life, but drug abuse is in addiction. It's not just another lifestyle. And I think I would have the body of governments and professionals and public around the world would agree that it's not just another lifestyle. Anybody who's known a person who is addicted knows what happens to the family, to their life. Right. So,
well, Dr. Mangham, thank you so much for joining us today. Is there, I guess, few words of imparting wisdom you have with us before we go?
Addicted persons are people. They're salvageable. Whatever else you see in them, they are valuable, and that they maintaining them on drugs is not the answer. And safe injection sites, nowhere have we seen that they are feasible and capable of actually making a difference, because in free populations, you haven't got the capacity to control people's behavior. So I would be cautious moving forward to use my resources in the most compassionate way possible, and not maybe the cloak of superficial compassion. Well, if they use this, maybe we can keep them alive, but it's not really doing that. So that's my thoughts, and I wish you the very best in California.
Yeah.
I have a brother that lives in California and loves it.
We got
And everybody loves California.
Right. Right.
And I appreciate you having me on.
Well, thank you for joining us, and thank you so much. And hope to hear from you again on this issue. Very interesting. Thank you, Doctor.
Well, thank you.
All right.
Are called dreamers.